Welcome to the EAU podcasts. In this episode, recorded at European Multidisciplinary Congress on Urological Cancers 2024 in Lisbon, Professor Bedke talks about the key topics from the plenary session on kidney cancer updates, the role of the cytoreductive nephrectomy in SUNNIFORECAST trial.
Hello, everybody. It's my pleasure now to report from this year's EMUC Congress in Lisbon. And one of the main questions in the RCC key session was the role of the cytoreductive nephrectomy. And cytoreductive nephrectomy is definitely a topic which is of high interest and not without any tension between the oncologists and the urologists, and also what we learned from the radiation oncologists who presented data on treating the primary tumor with SBRT, which is called SABR, what I learned here. So, the data for the CARMINA and the short-time trial of immediate versus deferred nephrectomy or in the immediate start of systemic treatment compared by secondary nephrectomy has been well published, and we all know that for the TKI monotherapy. As of now, there's no data available for TKI-IO combination or the ipi/nivo CTLA-4 PD-1 combination in this metastatic setting for the question of cytoreductive nephrectomy. What we have learned, cytoreductive nephrectomy has its role in this setting, and this was broadly discussed at the Congress. So the majority of people agree that cytoreductive nephrectomy should not be performed in IMDC poor prognostic patients. On the other hand, if oligometastatic disease tumor burden is low or the patient is in a good performance status, upfront cytoreductive nephrectomy still has its role, and they'll know that from the subgroup analysis of CARMINA with IMDC 1 point that there is a benefit for this approach. On the other hand, Professor Axel Beck's short-time trial clearly demonstrated that the immediate start of systemic therapy is of importance if you're in doubt if the patient needs a response and should not undergo direct cytoreductive nephrectomy if the drug is needed to treat the systemic disease. So for the question of upfront cytoreductive nephrectomy, as discussed here, I think there are clear roles. But cytoreductive nephrectomy does not only mean upfront cytoreductive nephrectomy. I think personally it means the incorporation in a multidisciplinary team, being the urologist as a key player here to stress the importance of surgery and defining the right time point. I think we all agree the systemic therapy has proven a lot of benefit in terms of efficacy, progression-free survival, overall survival improvement. And now, what is the right timing for cytoreductive nephrectomy? And we discussed that here at the EMUC Congress. So if you start systemic therapy due to the metastatic disease, the performance status of the patient, and the patient is responding on a TKI-IO combination or ipi/nivo combination, then we should always think of a secondary nephrectomy or a delayed cytoreductive nephrectomy in this setting. What may be the optimal time point? And definitely opinions here vary. I think the first actual reassessment, and we know that the time to response is usually a little bit less than 3 months, should be waited. So not cytoreductive nephrectomy in a delayed setting prior to 12 weeks on treatment. The usual time frame, which was discussed here, ranges between 12 to 24 weeks, sometimes even a bit longer, depending on the patient's status of remission. And we should not forget in this setting, if we go back to the CARMINA trial, which is an excellent trial of immediate systemic therapy, that in this arm, that patients who have started sunitinib treatment, a high rate, 1/3 of the patients underwent secondary nephrectomy. And compared in the subgroup analysis, these patients had a pronounced overall survival benefit compared to the patients who just stayed on the systemic therapy. And second, we should not forget that the primary in the kidney poorer response to the systemic therapy with the TKI-IO combinations than the distant metastatic disease. Well, this, of course, leads again to the concept of cytoreductive nephrectomy, but timing is what matters right now.
And what about the SUNNIFORECAST trial?
SUNNIFORECAST trial, which was presented at ESMO meeting this year. So SUNNIFORECAST is a prospective randomized phase 2 trial using the 2 checkpoint inhibitors, ipilimumab plus nivolumab versus a standard of care in non-clear cell renal cell carcinoma. So patients in SUNNIFORECAST, as being a phase 2 trial, had a non-clear cell histology, which was centrally assessed, and it was not restricted to any certain entity like papillary or chromophobe, so everybody could be included. Patients were randomized 1-to-1 to receive nivo-ipi versus standard of care, which was mainly a TKI monotherapy. And the primary endpoint was overall survival rate after 12 months. In total, 316 patients were screened, 309 randomized, 156 to ipi-nivo, and 143 receiving the standard of care. Of them, 124 with the TKI monotherapy and only a minority, 17, with a TKI-IO combination. The trial was well balanced between the 2 groups, a classical first-line trial, as we know it from the IMDC distribution, favorable, intermediate, and poor, and also the common signs of metastatic disease, lung, liver, bone, lymph node were present. Of interest is that about 76% had any kind of surgery prior to the onset of the first-line systemic therapy. Of them, 70% having a prior nephrectomy or partial nephrectomy, as the trial recruited synchronous and metachronous disease. The histological subtypes had the majority in the papillary group with 58%, followed by chromophobe 20%, but also rare entities like tuberocystic medullary sarcomatous duct Bellini were included. Now let's have a look at the primary endpoint of this trial, which was significantly positive with its OS rate at 12 months in the ipi-nivo arm with 86.9%. compared to 76.8%. That makes a delta of about 9% between the ipi-nivo and the standard of care arm. And if you look at the Kaplan-Meier analysis, the curve starts separating early. The separation stays stable until the median follow-up time of 2 years. But if we have a post-hoc retrospective analysis and look at the OS rates, the formal level of significance, although it's statistically retrospective post-hoc and thereby not powered, loses a little bit its significance. So the overall survival, the median overall survival is 42 months with ipi-nivo compared to 33.9 months with the standard of care arm. Are there any specific subgroups who may benefit more from the ipi-nivo treatment? And if you look at the forest plot analysis for the overall survival, there are some interesting results, I think. So first of all, the PD-L1 positive patients, they had a more pronounced benefit than a PD-L negative patients, probably rethinking this discussion of PD-L1 positivity with ipi-nivo as we had that for the CheckMate 214 trial. Lymph node disease only do better if compared to systemic disease in bone, lung, and visceral disease. And there's one specific entity, the chromophobe renal cell carcinoma, which is actually not very vulnerable to the TKI-IO combination therapy like Len-PEM or Nivo-Carbo. They had a more pronounced benefit of a hazard ratio of 0.59 compared to the TKI monotherapy. On the other hand, patients having a papillary carcinoma, there was not really a benefit for the overall survival for ipi-nivo if compared to the TKI monotherapy. What about subgroups? Subgroups of IMDC favorable and intermediate. Well, we know the classic that for intermediate and poor, the benefit is more pronounced, so favorable. There's not really a big benefit comparing ipi-nivo and the TKI monotherapy. With progression-free survival, median progression-free survival was 5.5 months compared to 5.6 months. So there is no difference. And this mirrors a little bit the results, what we have observed in CheckMate 214. So the overall survival benefit with the ipi-nivo combination, not really a big PFS difference here, no really a PFS difference. What about the response rates? And we know that ipi-nivo can provoke high CR rates. The CR rates in SUNNIFORECAST were 8%, overall response rate 33%. with a higher primary progressive disease rate of 34.4% compared to the TKI monotherapy, which had, a lesser objective response rate, like 20%. Well, let's summarize this trial, and I think SUNNIFORECAST is the first phase 2 trial in an academic setting in the European community, which fully recruited, which fully included all non-clear cell entities, and which demonstrated the efficacy of ipi/nivo with the primary significant improvement of the overall endpoint of 12-month survival rate. On the other hand, who may benefit and what is relevant for the clinical practice by ipi/nivo? Maybe we reinforce the same discussion for treatment selection between ipi/nivo and the TKI-IO combinations as they had it for the clear cell population in the metastatic first-line setting, PD-L1 positive status, a longer overall survival, shorter PFS of ipi/nivo if we compare that. Of interest for the future will be, of course, if we could redesign such a trial based on the papillary and chromophobe subtypes, not including, all non-clear cell. But I think this is a historical development because a 300-patient trial in this setting, academically based, aimed at the beginning to have an all-comer result and all-inclusion to fully recruit.
Thank you for listening to this episode of EAU Podcast. To keep up to date with kidney cancer developments, visit our educational platform, EuroOnco Kidney Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU podcast channel for regular updates.